can we make a start, please? As you can see, our chair has sent his apologies today, so you have to suffer me as the vice chair for the purposes of this meeting. I've also, as will be abundantly clear, got a cold, so excuse the odd bout of coughing. I know that all the people who are in the public gallery, we're delighted to see you, have heard the information about the distinction of public meetings and so on. So I'm not going to repeat that, but I am going to ask people to just go around the room and do introductions, because I know there are a couple of people who have not previously perhaps been here. So David Knowles, normally Vice Chair of the governing body.
James Murray, CFO for West South London. Jim Smiley, lay member for the CCG.
Catherine Yates, nurse member.
Paul Gallagher, lay member and audit chair.
Annette Pouts, GP member.
Neil Ferrelly, Director of Finance for the CCG.
Ben Luskin, Chief of Staff, South West London.
Fergus Keegan, Local Director of Quality.
Hi, I'm Martin Ellis. I'm the new Interim Director of Transformation.
And welcome.
Thank you.
Hello, I'm Iona Liddington. I'm Director of Public Health.
Atin Gold, GP and Chair of the Council of Members.
Nadeem Neem, Second Degree Consultant.
Tony Michaelides, Managing Director.
Jade Andridge, Governance and Business Lead.
Thank you very much. Declarations of interest. Are there any to be added to the list? If not, we can proceed and review the minutes of the last meeting, which was held on the 3rd of September. Everybody's had an opportunity to review these. Are they accepted as a correct record? In which case, thank you very much indeed. We do have some action log with 3 items, but they seem in 2 cases to be satisfactory because they're on track, and therefore, are there any other items on the minutes of the last meeting that anyone wants to reference? If not, thank you very much indeed. Let's move on, and we go to the are there any items that members of the public wish to give us notice relating to items that are coming up on the agenda? I will, as usual, give opportunity to ask questions in relation to the items as we get to them, but is there anything you want us to particularly pick up at this stage? Thank you. The items taken in the private Part 2 session at the last meeting were, as set out here, the South West London CCG's merger application and the next steps for the development of the Kingston Intermediate Care Beds, and that is for noting. The Managing Director's report. Sonia.
Thank you, Chair. Quite an extensive report this time, so I'm not going to go through it in detail, but I'd like to start with a few changes we have both to the membership of the governing body and welcome Martin to Kingston and Richmond. So people will recall that Pete Smith resigned from the governing body several months ago now, and Atin has now stepped in to fill the vacancy that has risen as a voting member of the governing body. So I'd like to welcome Atin into that role. People will know Atin is the chair of the council of members, so it seems to make sense that he also became the voting member of the governing body. So I'd like to welcome him into that role. And also, I'd like to welcome Martin as our Interim Director of Transformation. And just for the record, for those of you will recall that Julia Travers is now retired. She retired at the end of October. So I'd like to, for the record, our thanks to Julia for all the work she did in Kingston for many years. I know that she absolutely predated me coming to Kingston in 2011, so I know she had a fantastic send-off, and thank you for everyone who contributed to the numerous events that we held. But I'm pleased to say that she's now in New York, so she has officially left us, but Martin has come to join us for the next 6 months. Martin comes from Croydon, so he hasn't come that far away, so he's part of our South West London Alliance as well, so great to welcome Martin. So moving on to the report proper, as I say, quite a lot of information in this month's report, so I won't go through it all. An update on SEND and particularly the areas of focus that we've been taking forward since we last met. And as you can see, there are things around making sure that we have robust educational health and care plans in place, that we absolutely ensure that we are reviewing those plans on an annual basis, and that we as a CCG have the right strategic leadership and monitoring in place to ensure that we are meeting the asks of the 2014 reforms. So that piece of work continues and remains a high priority for the CCG over the next month and into next year. Moving on, I've got some really good news for those who have been sitting around the table for a number of years now. We have now achieved the dementia diagnosis target. And again, I'd like to, and that was in September. I haven't seen the October figures yet, but in September we made it. And that was the first time that we achieved the dementia diagnosis target. If you recall, the national target is 66.7%, and in September we reported a performance of 68.2%. I'd like to, again, thank everyone who's worked so hard. I know this has been one of those really difficult targets, but it shows that by working together and having a clear set of actions that we can achieve targets if we work together. So that's really good news, and fingers crossed that we can maintain that level of performance going forward. Moving on, another development that I'd like to bring to the attention of the governing body is the opening of the Mental Health Crisis Cafe for Kingston and Richmond in November. It will be running 7 days a week, but it will be shared between the two boroughs. So during the week, Monday to Friday, 3 nights it will be in Richmond and 2 in Kingston. And then at the weekend, there will be 1 cafe each day, one Saturday or Sunday in both boroughs. But of course, the cafe is open to anyone in Kingston and Richmond. So the location is not dependent. You don't have to be living in the borough to access it, which is something that I'm very pleased that we are able to support as an alternative to emergency departments for people in crisis. It will be operating 6 to 10, 2 evenings a week in Kingston, and 2 to 8. But as I say, 6 to 10, 5 days a week, and 2 to 8 for 2 days at the weekend. So that should be opening in November, and we'll absolutely make sure that we have the right communications around that for the populations. I don't know off the top of my head, no. I think we have got a premises, Rob. I just don't know where it is. I can't. I don't. It has to show. It has to serve the whole borough. I think we have a site, but if we're opening in November, we've got a site.
That's fine, Rob. But we will stay with our usual procedure and let Tony.
Yes. So if we're opening November, we have a site. I'm just off the top of my head. I just don't know where it is, but we obviously will communicate. And it is a pilot. So actually, if we find that the site that we have chosen for Kingston is not optimal, we will look to relocate, but we do try to ensure that our location is as accessible for the whole population as possible. Moving on, we also have an update on our planned care transformation programme. Members will recall that the long-term plan published in January 2009 states that the traditional model of outpatients is outdated and unsustainable. We have got a programme work with the hospital and the 3 boroughs, CCGs, that are the main users of the hospital. That's Kingston, Richmond and the Elmbridge locality. We're starting looking at a number of clinical areas, particularly gynaecology, respiratory and neurology, and we will obviously communicate our programme as it develops over the next year or so. And that's what leads into the next item around an update of how we're working together to integrate health and care across Kingston. And we are now going to start developing our local place offer in Kingston that brings together health and care leaders from the NHS, Local Authority Health Watch and the voluntary sector to start talking about how do we want to work together in the future. And so moving on again, just to remind members, and we have looked at this in the seminar mode, that the discussion document around the South West London 5-year strategy, which is our response to the NHS long-term plan, is out with partners at the moment, and we are just in the process of collating feedback from partners around we have laid out in our response, and we will be publishing our South West London strategy in the near future. And finally, just to assure members that the mental health and wellbeing of our staff is really important, and we use the World Mental Health Day on October the 10th to promote the wellbeing activity that we make available for our staff, just to also assure members this is not a one-off thing. We have a programme that runs throughout the year, but we use the World Mental Health Day to really promote support to our staff around their emotional well-being. That's all I was going to say this time, but I'm happy to take questions or comments. Thank you.
Microphone on. Questions from governing body members? Nope. Any questions from members of the public? Rob, do you want to pursue that point? No. All right. Any others? If not, thank you. We will move on to the Audit Committee's Chair's report, which is verbal. Paul.
Thank you, Chair. So just a quick update for the governing body. One might help. Thank you. So the last meeting of the Audit Committee for Kingston was held September the 24th. And I think the key issues we went through there, so from an internal audit perspective and working with our internal audit partner, since that meeting, the one report has been completed, which is the acute contracts audit, and that was completed and issued with a substantial assurance opinion, which was very positive. And from the interim reports, we're showing overall improvements in insurance levels, and that is in line with other CCGs, alongside the number of internal audit recommendations are decreasing. So again, that is a trend in the right direction and a positive outcome. With regards to the local counter fraud services, there was just one issue raised in June, but that was investigated and closed with no further issues required. I think the final item regarding Kingston was just the confirmation of the external audit for last financial year, 18-19. That report has been issued and letters completed now, and as people will recall, that was issued with an unqualified opinion. So there's nothing further to add there. I think the only other thing I would bring to the attention of the governing body is we held the South West London Audit Committees in common last week. And I think what is probably relevant for the governing body to be aware of is just the agreement. We will work with the Oversight Committee that as we move towards the new arrangements for the CCG on 1st of April, the Audit Committee members will take some part in that and just assure and give governance oversight. Otherwise, Chair, I think that's all that's relevant for this governing body.
Thank you, Paul. Any questions relating to the audit report from members of the public? If not, thank you. We will move.
So the Finance Committee met during the month. We reviewed the month 6 report, which we've included in the pack. We also discussed in quite a lot of detail the QIP position. The QIP currently is forecast to deliver £9.7 million worth of savings against our plan of 11.3. So that was the other area of focus for the Finance Committee. Okay, so this is the report for month 6. If I take you to page 70, just the summary page. So the main things to just update the board, as at month 6, we're still reporting to meet our break-even position overall. The net risks we're now showing at 490,000. That's mainly because we have used some of our mitigations to manage some of the extra CHC continuing healthcare pressure which we've had in this month. The underlying position is now showing a deficit of 4.1 million. So that's our costs on a recurrent basis are about 4.1 million higher than the allocation that we receive. I just take you to page 86 in the pack. That just gives you the detail of the position. So you can see in this table on the on the left-hand side in the third column, those show the recurrent and non-recurrent variances, and you can see the largest pressure is continuing care, where we're now showing an overspend of continuing care of just over 3 million. The central box is removing all of the non-recurrent items in order to get back to a recurrent position, and I think the main value there is the 4.1 million in the acute services line, and that is where we've put all of our non-recurrent balance sheet measures. So a lot of the underlying position is being masked because of the benefit we are taking in managing the position with non-recurrent measures. And clearly, one of the big areas of overspend is now the continuing care spend. The other thing I just wanted to go back to was page 74 in the pack. And this is just our Kingston Hospital position for month 6. This table shows the overall position for South West London as a total. And if you look at the second blue line in the table, we're now showing a reported variance of 1.3 million. We have a tolerance of 2% within the contract, and at the moment, as at month 5, we're now at 1.74%. So we're within the tolerance. So there is no further payment that we need to make to the trust. But if you look at the Kingston column, the second one on the left, the major pressure is still critical care and the emergency activity, and less on the A&E activity proportionately than some of the other CCGs. I think those are the main bits I wanted to highlight.
Any questions to Neil from members of the board? I just want to pick up the Kingston one because, yes, we have 2% tolerance on the overall contract with them, but it's running very high at the present time, probably higher than we would have anticipated at this stage in the financial year. Is that also your view, Neil? And how do you see this developing in the remaining months?
Yeah, I think I share some of your concerns. I think one of the factors we have picked up, though, is within the table, the critical care costs we're seeing. We only get charged critical care costs once the patient has actually been fully discharged from the hospital. So quite a large proportion of that 452 relates to a large number of days for critical care, which actually incurred between July and September of the previous year. Since we've been tracking that now, we're not incurring such a large cost for critical care cases in year. So we think there's a slight distortion there. One patient was actually a critical care patient for 179 days during that period. So I think that's partly why we've got...
They came into the hospital presumably last financial year.
And was ironically discharged on the 1st of April, so it only fell into our books because they actually left on the 1st of April.
That may or may not be seen as an advantage for Telly. Yeah. So there is a degree of confidence that we'll be able to survive within the tolerance limit that was set at the beginning of the year.
Well, there's still quite a risk because we are relying particularly on the underspend with Wandsworth to manage the position. But we have profiled and we've got a proportion of the plan is back-ended to manage some of the winter pressures. Yep.
Other questions? Liz.
Yes, it was just in relation to the winter pressures. I've been reading in the paper that Australia's had a bad flu season, and apparently when Australia has a bad flu season, we tend to, follow with our winter season. And I just wondered what the modelling has been in relation to flu and the effect on winter pressures at Kingston Hospital.
Take that, shall we give it to Fergus? Fergus, please.
Thank you. So you're right. At a point in time, the flu modelling that was coming through from Australia did indicate that there was a very high prevalence of flu earlier on in the year. I think that spike was seen to rise earlier, but also diminished more quickly than would have been expected. So I think it's the same profile that we do normally see. It just occurred earlier. So concerns were raised early on about that, but the risk of that has diminished somewhat. As you know, an important part of our winter management is the vaccination programs that we have in place. We've done a lot of work with local providers to ensure that they have very high uptake amongst their staff. Really pleased to say that we offered it for all of our CCG staff as well over a couple of episodes in the last couple of weeks. There is always a degree of being hostage to fortune, so whilst I'm giving the assurance that the data from Australia does indicate that we're going to have a more normal period now, there is an element of we will need to wait and see how winter shapes up.
James?
Yeah, I mean, this is just a general point really on those numbers, because I think what it's showing is, as always with these things, is organisations tend to go through cycles. So whereas we've had a stable financial position in Kingston CCG for the last few years, the numbers that Neil's showing effectively mean we're going into next year with a deficit. So that's going to put big pressure on our planning as we go into next year. So we're going to need to start to turn that around, and the way we work through the next few months to develop that plan is going to have to be really robust to make sure that we go into next year with a strong plan that can deliver our financial targets. But that's just a different position we're into what we've been used to for the last 2 or 3 years, certainly in my time around Kingston. So it's just a heads up that that pressure is going to be there, really.
Annette.
I probably just should also mention that we're having quite a high, so some of this emergency stuff at Kingston is respiratory, quite a lot of it actually, causing the high costs particularly. And it seems to be particularly chest infections. So we're actually busy trying to look into that at the moment. I have just got some data back yesterday, actually, from our practice. We thought, and I've asked public health to look into pneumovac vaccine uptake as well, which is the pneumonia vaccine. And certainly when we looked through all our patients in the last 12 months who we've coded as having had a lower respiratory tract infection or chest infection, 2/3 of those patients have not had a pneumovac vaccine. And so it may be that we've had a slight fall off in uptake, and that might be responsible for some of the increase in pneumonias. It has been, some of that increase has been in younger patients, but younger patients at risk, so patients with asthma or other underlying lung conditions or other chronic diseases. So they are potentially a group who would be eligible for the pneumovac vaccine. So it might be, once we investigate a little bit further, that a public health campaign and a primary care campaign to increase pneumovac uptake again might help us with some of that pressure, but obviously that will only come in the future.
Thank you. Any other comments from members of the governing body?
So there isn't an NHS policy in place to mandate that staff must have. People are entitled to make a choice, and some people will make a choice for their own personal reasons to not have the flu vaccine. That being said, we spend a lot of time encouraging staff, providing them with the facts, helping them to make an informed choice, but there is no mandate. We cannot enforce a vaccination regime within staff.
Well, patient choice has operated for a number of years without the benefits of e-referrals. So we've always had that system of people moving around and making a choice about where they want to go for planned care. You are right, but we tend to model it based on the fact that the trust has a fixed amount of capacity for certain services, so we can reasonably predict, particularly with planned care, how many conditions we might be having to treat in a particular period.
But can I say, I think that
I would want to challenge that, Rob. I think it has been known for a long time, and there has been a consistency in the pattern which is observable across the country as a whole, and that's there's been a lot of analysis about what that comprises, and the King's Fund have a significant report, a couple of years old, but nevertheless, which demonstrates that. I think it's always changing, and the thing that you've heard me talk about before, when I've been sitting over there, is for example, the impact of Hammersmith Bridge closing on the A&E department in Kingston. And that is clearly a new factor which has to be reflected in the analysis of A&E at that hospital. But I think there is good data which enables the forecasting, and of course there are changes that are going to occur all the time which have to be reflected in that analysis. Fergus, do you want to add?
So I'll just add that we use a lot of historical data to forward plan. And probably the two biggest factors that influence patients' choice are their proximity to the provider, so how close I am, and what my GP thinks. There's a high degree of trust in the response from your GP when the patient will quite often say, where do you think I should go, or where would be best for me to go? And indeed, GPs will express a degree of choice. They may say, I think you should go to cardiology at Kingston, or they may say, in some circumstances, I think you should go to cardiology at St. George's. Far and away above every other factor, those two are the two that influence what people's behaviours are. A small number will make choices based on their experience. If I've had a good experience somewhere or a bad experience somewhere, that will influence choice, but for the vast majority, it tends to follow those historical patterns.
I take your point, Rob, and you may well be right, but we have had a lot of data about trends across the population and the extent to which people use alternative services, the ones which are local to them. Richard?
Yeah, just to add one point before I want to make the point I make. The flu...
I'm sure you could argue that there are huge numbers of health implications for the cycle lanes, but I think that's a topic we on the whole might be wise to avoid at this stage in a public meeting for the CCG. Thank you. Any other comments? If not, we will move backwards. I'm really sorry that I should have gone straight past the Integrated Quality Governance Committee, which is actually one of the really significant reports that we receive in these meetings. So, Fergus, and we all have to scroll back to get to the right point.
Thank you, Chair. You were just checking if any of us needed a referral for dementia assessment there. There were a few people who spotted it very quickly. Apologies from Phil Moore, he's not available today. The report I'm going to talk through, as usual, comes in three parts, looking at the most recent performance, some narrative around our operating plan, and then some feedback from some of our clinical quality review groups. I will touch on a couple of areas of both positive and less assuring data points within my narrative. On page 6, really pleased, as Tonya has mentioned earlier, to see right at the very top our dementia diagnosis rate has become green. And many of you will know I'm predisposed to green on my charts. But just by way of update, it'll be about another 10 days or so before we know what the next month's data is. So we'll pick that up at our next GC. In terms of referral to treatment standards, this is an area that historically we have performed extremely well within the Kingston area, and as I have mentioned previously, the recovery plans at both St George's Hospital and Epsom and St Helier for Kingston patients has been pulling down our overall performance. But that is now to such an extent that combined with Kingston Hospital, it's going to make it unlikely that we will hit that year-end target at the year-end, given the period of the year that we're just about to head into. So that's probably the one thing in terms of less good news that I would want the governing body to be aware of. In terms of the 6-week diagnostic standard, we've had a challenge, particularly at Kingston Hospital, with regards to access to the echocardiography service within 6 weeks. The Trust has taken the opportunity to negotiate a managed echocardiology service, which will come into place in the coming months. And our anticipation is that we will get back on track for the year end with regards to our diagnostic weights. We continue to perform extremely strongly against all of our cancer standards. And then for some of our mental health standards, we have been performing particularly well with regards to early intervention to psychosis and the care plan approach, and also our access to mental health services for children and young people. We're ahead of the 34% standard. We're almost 50% ahead of that required rate for the year to date. An area that we're getting better at, but we have a little bit of work to do, is with regards to physical health checks for people with serious mental illness. And we're now making sure that the governing body are more cited on both that, but also the physical health checks for people with learning disabilities. Both of those are areas that we would want to see green by the end of this year. We continue to perform well with regards to delayed transfers of care, which is an important strategy for a supporting flow in the hospital and out of the hospital. And as I have previously talked about, our accident and emergency waiting times continue to be a challenge. That being said, there has been a lot of work at the Accident Emergency Delivery Board. A number of members around the table here, both clinical and managerial, are members of that. There has been a lot of work, and the assurance process, the annual assurance process, has now been concluded both at a South West London level and a London level. And as a system, I think we're as well prepared as we can be heading into what will be a difficult winter. With regards to continuing healthcare, again, we perform particularly well with regards to our personal health budgets. So these are patients where we give them more control over how their funds, their health funds, are supported and spent. And actually, we're reporting well ahead of the year-end trajectory already at this stage, and I'm expecting that we will continue to support that in the coming months. In terms of operating plan, you'll see there are a couple of areas that are challenged. One relates back to the earlier commentary about the increase in activity in accident and emergency, and in turn then the onward care of those patients has led to a greater level of total other referrals than we had planned for within our operating plan. The other is an area that we have talked about. Again, it's an artifact of the new reporting requirements. This is in relation to outpatient procedures, where the way that they were unbundled or decoupled from the outpatients themselves has led to an artifact that all of the overperformance in that area is as a result of that. In terms of the clinical quality review groups, there are no areas that I'm particularly concerned about that I would wish to draw to the attention of the governing body. Safe to say that we received the the 6 monthly updates on staffing from both Kingston Hospital and from South West London St George's Mental Health Trust. They're important pieces of assurance for us to receive about the activities that the trusts are undertaking to ensure that they have good recruitment and retention strategies, and that the supply routes of staff for patient care is good. At that point, Chair, I'll pause and say I'm happy to take any questions.
Questions for Fergus? Liz?
Yes, I've got one general question and then a more specific one. The general question is, this is a very useful document. After the end of March 2020, when we have a South West London CCG, will a similar paper for Kingston be in the public domain?
And Ben might want to also mention. So I absolutely know that we will develop our reporting to South West London CCG that is able us to identify borough performance that will be in the public domain. So I, as the local lead, will want to make sure that I can absolutely see that we're not only are we making a performance target at South West London level, but also we're making it a borough. And I think the dementia diagnosis is one case in point, isn't it? So if you look at the South West London dementia diagnosis, we are more than overachieving that target. As a collective, I think we're over 70% if you add up every borough's performance. But that's not good enough for the population of Kingston, so we continue need to know what the performance is for Kingston so we can make good for our population so we have equal coverage. So absolutely, because actually we have a fully delegated model within South West London as a CCG, and to be a fully delegated model you have to have not only the money, you also have the quality and performance. So I think we need to make sure that we iterate that performance report over time so that we make sure we get it right. So I'm not saying it's going to be absolutely perfect the first time we meet, but there is absolutely every intention to have not only a South West London position, but also the constituent borough positions in that as well.
And my specific question is related to a comment earlier on in relation to health visiting numbers. I must admit I am easily confused, and I was confused by this. It says that CCGs are monitored on health visiting numbers by NHS England, but the report also notes that reporting on HV numbers is a public health responsibility and isn't therefore reported in this document. So firstly, where is that monitored and in what document? And secondly, if it's a public health responsibility, but it doesn't have to be reported here, why is NHS England monitoring the CCGs on it? I found all of that rather confusing.
I can understand the confusion. Iona, can you help us?
I'm not sure I can clarify everything, Liz, but I think it's initially when Public Health moved over to local authority, health visiting still remained with PCT, or CCG as it became, and it only moved across the local authority in 2014-15, partway through the year. So it's possibly a historic reporting mechanism. Clearly, in terms of pathway for families, it's important. So Public Health also report it through the council. We also report it to the Children's Commissioner. It's something we have very frequent freedom of information inquiries. So we do collect the data from our provider frequently. So I think it's potentially partly a historic artefact, but I think in terms of looking at pathways for families, it's quite important it comes here too. Just it doesn't form part of the
It's just that it isn't actually reported on, though, in this document, which is what I find confusing. So it is reported on at a council committee, you said?
I think we have reported it on an occasional basis. We don't do it statutorily, like once a year, to Health and Wellbeing Board, but we could look to do that if that would be helpful, and we could look to provide the information here. It's just that it's not a CCG requirement, if you like.
And can I ask this Fergus just to complement that?
I'm not sure why everybody's got excited about health visiting today, but in another place I was asked about health visiting numbers this morning as well. We've reported it this way for the last 3 to 4 years within this committee. I think it is an artefact of when public health was moved, or the reporting lines moved. Well, if it's helpful, Chair, what I did offer this morning was that at the next IQGC, not the one that's happening next week, the following one in December, that we would work with Public Health to have a short report to come to IQGC around health visiting numbers and any interesting or related facts around staffing levels or caseloads and the like. And then from there that I would bring a report back to the January governing body. I'll append it as some additional narrative within my performance and quality report, if that might be helpful and might give Liz some visibility and assurance that it is monitored and kept a check on.
Yeah. I think it would be extremely helpful, and it would be a proper expression of the response to the question that's been raised. Liz, anything you want to add?
Just a comment that it probably hasn't been mentioned before because I've only just woken up to that particular statement, but also to note, I think the House of Commons had a debate on health visiting a couple of weeks ago.
Thank you. Any other questions? Rob?
It's actually just a comment. I would like to say a big thank you to the A&E.
And the gentleman in the back row whose name I don't remember. David.
So I think I've highlighted just in summary a couple of the actions that we have identified by way of support for practices around improvements. I think I would say I'm pretty confident that we will hit both of those thresholds. Mental health and all matters related to mental health, I think, have quite rightly come up the agenda, both in primary care but also in secondary care and indeed within political and other arenas as well. I think there's that additional focus, sometimes shining a light on what the actual performance is. That in and of itself derives some of the improvements. But there's some support in place for practices through our locally commissioned services route and our practice. So we have staff within the CCG who are allocated to work alongside with practices and provide support to them. And I'm really confident that actually that will move forward. Our managing director is the Southwest lead for mental health, and Phil Moore, our deputy chair, again has a similarly a very keen interest in matters related to mental health. So I think strategically as a CCG we take this very, very seriously indeed.
Thank you. Any other questions? If not, thank you, Fergus. Now let's move on to the Council Members' Report. Atin.
Thanks, Chair. A brief report from me today because the last two meetings were predominantly focused on moving forward together agenda. So at the September meeting, we had an update from Dr. Naz Giovanni, Sarah Blow and Tonya McLeides. We also welcomed Dr. Geoffrey Croucher, the chair of Sutton CCG, and he provided a perspective from their side of things and advised that the members that the 6 South West London chairs had been working very closely to make sure that the proposed merger was the right thing to do. Members of the council members were given the opportunity to further feedback into the emerging constitution and the supporting documents. And Dr. Naz Giovanni had been conducting practice visits to individually consult with practices. Sarah Blow also assured members and stressed that the South West London chairs were committed to building on the vast amount of work that had been achieved at borough level over the recent years, and that would continue as we move forward. However, the South West London CCG would mainly function where it makes sense to deliver work over a larger footprint. At that meeting also, as Tonya's already mentioned, the members were advised that Dr. Pete Smith had resigned as a governing body GP and that the chair of council members, I myself, would fill the role in the interim until March. And then at the October meeting, we conducted the vote with the LMC present, and they oversaw the process. We had representation from all 21 Kingston practices, so we were 100% quorate, and all 21 practices voted in favour of the new constitution, bringing together the 6 South West London CCGs. And that sums up really what we've been doing for the last few months. The next meeting is on the 12th of November. Thank you.
And I realise behind that report lay a huge amount of work and commitment from you and Naz Giovanni and others in having a proper analysis of the advantages of the proposed change. And of course, we welcome the fact that you were able to decide to go down that route. Any questions relating to that report? If not, can we move on? Tonya, I assume you're going to present this next item to us?
I am going to let Ben present the next item because he wrote the paper, so I thought that would be, but I'm sure Ben doesn't mind doing it.
Ben.
Thank you very much. It's a relatively short paper, so I'll keep my overview of it relatively short as well, and it follows on from what Ashton was saying, actually. So we submitted our application to merge the 6 South West London CCGs to NHS England on the 30th of September. Sarah Blow, James and myself then attended a merger assurance meeting with NHS England on the 15th of October when we went into more detail with them about the overall strategy of CCG and some more detail about 10 areas of which our application was assessed against. In the intervening period between the end of September and that meeting, as was referred to earlier, we went through the voting process across all of our 6 CCGs on the Constitution to support the new CCG, and all of the 6 voted to support that. So on the basis of that, NHS London Region team assessed our application as being low risk and approved it in mid-October. So we're therefore on track to abolish the 6 CCGs at the end of March, and the new South West London CCG will come into effect on the 1st of April next year. Key milestones then coming up to make that happen. We've obviously got a new structure, a draft structure that has been designed to support the new CCG. We will start a consultation with our staff on that later this month. We hope to finish that by the end of December. We'll publish our response to the consultation to our staff early January, and we hope to start filling the positions in the new organisation mid to late January. That's all I was going to say on that at this point, but I'm very happy to take questions.
Thank you. Questions from members of the governing body? It's clearly a very critical phase as we start to consult formally with our staff, and it's something we appreciate. It's a time when there's uncertainty and anxiety on the part of many of them, so it's crucial that it's done effectively. It's also the case that it's quite a tight timetable, so we recognise the pressures of that. Any other comments or questions? Rob?
In your constitution, are you heavily emphasising that, I believe, 80% of the
So firstly, we're not doing away with the primary care meetings. There will be a primary care committee that exists at South West London level, and then we'll have a primary care management groups that will exist at borough level, and that will be where most of the work is done. So I think you need to view the Constitution not just as the Constitution by itself, but as the suite of documents that goes with that as well. So there are about 10 supporting documents that form the basis of our governance structure. Really, so the Constitution itself is based on the model Constitution across the country, which all CCGs we'll use and abide by, with some local tweaks to that. The delegation arrangements are set out in the scheme of delegation and the other agreements we have with that, so such as the borough terms of reference and the accountability agreement that we've got, that we will put in place with each of the boroughs, and we're working on the principle that it's 100% delegation, but there'll be certain areas that we will want to and make sense to do at South West London for economies of scale and efficiencies and population base, etc.
So I'm a bit nervous about
we are still South West London CCG. We can only have one CCG, obviously, across that. We've had a lot of discussion about what the local area, shall we call it, for want of a better phrase, this should be called. Borough was the latest place we landed. The organisation as a whole and the boroughs are still clinically led, so the makeup of the governing body of South West London has a GP majority and definitely has a overall clinical majority as well. That's written into the constitutional, the standing orders, and possibly both. The borough terms of reference, again, also set out a clinically led, clinical majority on the borough committees as well. So yes, very much still clinically led.
And I don't think there's any shadow of a doubt that in considering this by the all 6 council members, they would have been rejecting any proposition that was not clinically led in the new arrangements. That was a key feature in all of this. David.
So I'd probably say it's not extremely. I think it's very tight. I think there's a huge amount of work to do in that, but I do think at the moment it is doable and we're on track to achieve it. We have a detailed programme plan to deliver that. I think if there was, one of our big risks was whether if there was any delay to the NHS approval, that would have affected our ability to deliver it, but we've managed to do that and we're on track to deliver that at the moment.
And the timetable has been known for, well, 9 months, 12 months or so. So in that sense, it's been well planned. But the next few months are critical, of course, from the point of view, particularly of the staff who are affected by this. Liz.
I just wanted to comment on, I mean, it's reassuring to know that there's a whole suite of governance documents, but I think from a lay perspective, they will often feel very abstract, and what will be helpful to know is what agendas would look like at both the South West London level, also at the local level. The Primary Care Forum, which I think met in October, or it was October, which is an engagement meeting, I believe there was a promise that that agenda items, the sorts of things that would be on the agenda, would be circulated. In my view, that would be helpful because there is a rumbling debate involving the 6 South West London health watches, and we have another meeting next week on this with colleagues from the NHS in South West London about the extent to which health watches, which are mandated to represent their local population, if there is only one health watch representative at South West London, whether they can indeed cover the other 5 populations, because the mandate, it's highly questionable. My view is that the way forward on that would probably be that we have more concreteness about what the agendas would look like, because it feels that otherwise we may, continue to have a debate simply because it's at a level of abstraction. So if we can have the concreteness that was promised at the Primary Care Forum, and I believe Richard you were probably at it, and probably Rob was. That might be a way of solving that particular issue.
Can I ask Tonya?
So that I was at the primary care one. I don't know if it's concreteness, because I don't think that's possible at the moment. But I would look at, and I can give you a list, it's the sort of things that, what will be at South West London level will be the sort of things that go to committee in common at the moment. So things that are shared across more than one borough, things like the ECI policy. We did that at committee in common, we didn't do that here. We did the extended access effective commission initiative guidance, which is a common guidance that is across all 6 boroughs. So it's the things that will be done more in more than one place across more than one borough. So I'm really nervous about when we say concreteness, because actually set in stone in something that's evolving and emerging, and I don't want to exclude things by saying, oh, we said we were going to deliver it, talk about it here, we've done the piece of work, actually it makes more sense to do it at this place. But the sort of things I would look at is effective commissioning guidance, some clinical policies that are common across the piece. So another one that is always quite emotive is IVF, for example. That would be something that you'd look to do at South West London and agree. We've taken extended access monies because actually that is a pot of money that comes down at an STP level. The kind of decisions I think will be taken at a borough level is things like, what's our social prescribing model going to look like? What is our out-hospital model going to look like? What is our outpatient transformation going to look like across Kingston and Richmond? So that's where the 80-20% becomes. So we're 100% responsible for all the budget, but we know it's better to plan and manage at a South West London level or a bigger footprint, some of it. And I always use the example of inpatient mental health beds. We have 3 sites for inpatient mental health beds for South West London and St George's. It is much better for us to manage that at a 5-borough basis, because they are the 5 boroughs that use and access South West London and St George's. So I can draw you up a list that says these are the kinds of things, but it's not going to be exhaustive, because we don't know what happens through the long-term plan. If you look at the things about what the long-term plan is saying, so it would give you but I would say the guide is what are those pieces of work or strategy that are broader than one place, and particularly if they cover 6, such as effective commissioning guidance. The majority of our work will be decided and designed locally. But I can do a side of A4, but that's what I would look at, because I believe, does Health Watch sit on the committee in common? I'm not sure anyway. But we can get, so that's the kind of so I think we just have to recognise that this is a piece of work that we're moving forward together. And actually the CCG is an element of it. The integrated care system is another element, of which the CCG is just a partner of. So I think that's the thing that we just need to keep in mind, that this is not, we've done as much of the work around the governance, but we're going to test it, we're going to change it, we're going to work with it, because actually until you start running it properly for real, it's really hard to blueprint. And I think it hinders us by having something so bedded down at the start that actually if we need to make a change, that we can't do it in an open and transparent way if we've bedded it right down at the beginning. But I can put a couple of bullet points. It will only be a side of A4 to give you an example. It won't be everything, because we don't know everything that we're going to have to make decisions on. So for another example would be the IHT stuff, the around Epsom St Helier, when that gets to a point. But, as Kingston and Richmond, we will be there as participants. We won't be core decision makers within that. So,
just a comment. I mean, I'm less inclined to die in a ditch over this than some of the other health watches, and I'm just trying to. I'm trying to move this forward.
I do appreciate that, and I think it is just actually how do we keep the dialogue and transparency on these decisions and discussions, so people don't feel that. I think a lot of it is not feeling included in some of. As we go on the journey together. So I'll get something around, but I'll give you that's where I would look at things like the committee in common agendas.
I don't think there's any doubt that when you look at how other parts of London, particularly, are proceeding with this, the scale of delegation that's proposed for South West London is greater than the others. It's very extensive. And the clinical commitment has been absolutely secured of our clinical leadership, which is the point that was being made earlier. So I think in that sense, it is going absolutely in the right direction. The difficulty, of course, is this will evolve over the next 4 months in ways which are difficult to predict at this stage. But this is a public process. The new CCG will be a public body. And the reports between now and when it comes into existence on the 1st of April will be made through the existing public bodies, the existing CCGs. So in a sense, it's as open as it can be at this stage, but it's hard to predict precisely how in the detail this is going to work. But the fundamentals, I believe, are in place, and I think it speaks well of this area relative to the scale on which the same process is being attempted elsewhere in London. Rob?
Yes, I'd like to thank Tara, actually. She gave an excellent presentation, didn't she?
You know, I'm not wedded to the borough committee. I think, to be honest, we did want to have another word for it, but I think it was seen, local committee was the thing that was seen by the partners as not the right name. It's a name is a name, isn't it, in the end? I think there's only thing that is around...
Is the public perception of it, though?
I think there has to be some kind of standardisation across the piece, though. We spent a lot, as Ben said, we spent a lot of time. I mean, I think it's one of those things, Rob, you'll never satisfy everyone. So if we used local committee, because I wanted to call it local committee, there was another partner said you can't call it a local committee. So it's just a really difficult one.
Can we move on from this item? Thank you. The Board Assurance, we're now into the 3 items which are simply for our information. The Board Assurance Framework Summary. Anyone wishes to make any point in relation to that report? And also for information is the South West London minutes. Anything anyone wants to say? Thank you. And then we have the reference document of the glossary of terms, which is always presented within our papers. The date of the next meeting is Tuesday the 7th of January. Are there any questions that any member of the public would wish to ask at this stage? Richard?
Just something I...
Annette, can you help us?
So you're not wrong in thinking that that is potentially serious. I guess it depends when they date from, because I know there were some historical problems, and there was a time in the past where we often had to chase up discharge summaries, or only found out that a patient had been discharged when we got a phone call from them asking about medication changes, or from the district nurses to say, have you got the discharge summary, because apparently medication has been changed, for example. That, as far as I'm aware, is happening much less now. Certainly in our practice, we are getting quite regular discharge summaries, and we seem to be getting them now on the day that the patient is discharged. So it would be interesting to know when those date from. You know, if they're sitting on a system, they might be from 2 years ago. We don't really know if no one's accessed them. So I think that would be an important thing to find out. If they are recent, then obviously there's a problem that we're not picking up even as GPs, whereas in the past we have known that we haven't been getting discharge summaries regularly. So I would say would be quite interesting to know when they're from. I think it's probably not a problem that's happening right now. That is something that's historical, would be my guess. But
it's only relatively recently, isn't it, that all of these have been done electronically?
No, they've been done electronically for a while now, and certainly in the beginning there were problems. They've always been electronically done on Kingston's system and then sent to us in paper form. So these could date from then. You know, I think it would be useful to know when they are from. They have more recently been sent to us electronically as well, but they've always been created electronically, well, for a very long time anyway, on the Kingston system. So I think it would be very important to know when they were from, because they may be historical. Yeah.
Naeem.
Could we talk about this after the meeting? Because it is very important for us to know that there are discharge summaries which are not being seen and actioned on. And we sit on the Information Governance Committee, subcommittee, and it is something that we would investigate. So please, can I take the details off you afterwards, and we will look at it through our committee.
Thank you, that's really helpful. Rob?
Just a question. I'm very, very nervous if Kingston's talking about IT systems, because
Yeah, the process that we have in place is it's a push system from Kingston Hospital. So Kingston sends a discharge summary to the practices. It's news to me that Kingston have got discharge summaries sitting on their system, which don't seem to have been pushed to the surgeries. So that's what that.
They can tell whether they've been accessed.
All right. So we should investigate that. So I'll get the details off you afterwards.
Thank you. Any other issues? One last one, Rob.
Pneumonia jab, very interested. What's the criteria? I mean, our aging parents is in the Star and Garter. Do you offer like the Star and
So the criteria for getting the pneumonia jab on the NHS is if you are 65 years or above, or if you are younger than that and you have one of the eligible chronic diseases, so asthma, COPD, I think ischemic heart disease, diabetes, and there are probably a couple of others as well. I'm not sure, so anyone who falls into those categories can have the jab on the NHS. I'm not sure how it works in the Star and Garter.
And thank you. Anything that anyone wishes to raise at this stage before we close the meeting? Yes, Peter.
I'd like to raise a question, a comment about the patient's use of the electronic.
Can any of our GP colleagues help to respond with that?
So it hasn't come up as a councillor member issue, has it? So we can ask, because we do have at the councillor members, we have a session where members can raise issues. I don't think it's come up.
No, it hasn't come up. Atten will confirm that for a couple of meetings that I haven't been to, but it's also not something that we recognise in our practice. I don't think we regularly lose, the system doesn't regularly lose appointments. I don't know if you're having that problem, Atten.
So, specifically, which system? Are we talking about the Your Practices online booking?
Well, it's basically the surgery's booking system.
Okay.
So when the GP make the appointment while we were sat there, at a previous appointment, he made the booking on the system.
Oh, I see. Okay, so...
When we came to turn out, it wasn't there.
Okay, so that sounds like an internal issue with the system, that he may have booked it there and then it didn't save it correctly. But and also our appointment systems aren't linked into practice, so I don't think this would have, and it hasn't come up at the Council of Members. But if it does, I'd be happy to raise it and ask whether people have been having problems with their IT systems.
One more comment, and then we'll bring this to an end.
The appointment, I mean, all the practices in Kingston have EMIS as their clinical system, and the appointment system is actually integral to the software. So when someone books from an outside source, the bookings are all made in one place in the internet. And each appointment slot has got an audit trail on it. So the clinicians or the surgery can actually look on that appointment slot and see whether an appointment was booked, whether it was cancelled, whether it was reassigned or allocated elsewhere. So the practice should be able to look at that slot and provide an audit report. And if they can't, then they need to raise that with EMIS, because it is something that EMIS have built in. They've built in an audit trail for each appointment slot. So EMIS should be able to tell them.
Well, certainly the GP said he's got no way of finding out what cancelled the appointment.
But perhaps if it's raised with the practice manager of that practice, they can raise it with EMIS.
Well, thank you for raising those issues. I'm sure our GP colleagues will have taken those on board, and if necessary, there should be follow-up, obviously, to try to solve those problems. Catherine.
I was going to say, I'm actually going to the practice manager meeting tomorrow, so I'll ask the question there if anybody is aware of it at that meeting, just because I can.
Thanks, Catherine. That would be really helpful. We will close the meeting, and for members of the governing body, we have a part 2 meeting which will take place in the room immediately adjacent in 5 minutes. Thank you very much indeed.